Right here. And maybe a little over here. You want to see the wrinkles? You mean to wrinkle my face?
Yeah.
I'm just marking her now.
She's marking the muscles that cause the wrinkle, so she can be precise with her injections.
I don't care so much about that up there, unless you just think I need it, as much as I do this right here.
They have one in Sicily Road. The same stuff. Like not far from your house. So 2 years. 18 units.
And typically it lasts me about 6 months. Is that usually how long it lasts other clients?
Yeah, based off usage, it could last anywhere from 3 to 6 months if you use it a lot. Like some women who have done it for a long period of time might be 3 months, but I'd say from the ages of early 30s to early 50s usually lasts about 6 months.
Typically though, the more you do it, the more often you're going to need it. Is that what you're saying?
I'm talking about the people that get obsessive with it.
Okay. Oh, gotcha.
Yeah. Usually you can wait 6 months, but people that come in 3 months, they'll be like, they're having some motion.
And they don't want any motion. Okay. Is BOTOX FDA approved?
Yes. For the glabella.
For the what?
Glabella.
What is that?
Right here.
Oh, gotcha.
I definitely looked at $10 for you.
Very nice, Mary.
Oh, you're doing so perfect.
Okay, what do you want?
Not a flinch. It only feels like little pricks. Very small needle.
Huh?
All done. Or do you have any more? Yeah, all done. That's what I thought. All done.
In 3 to 5 days, you're going to look like my older sister.
Upright, 3 to 4 hours. Move the muscle to work the product in. Don't rub it in. And you're good.
4 days later, and here's the after. And so, is all your wrinkles gone? Are you satisfied? Or?
Oh yeah, I love it. Prior to having the BOTOX, I kind of had like permanent wrinkle lines here, and then maybe even across the forehead here, which if I make a frowny face, you know, like this or something, you still have the wrinkle or the little frown lines, but they're not permanent anymore. So they go away as soon as you take the frowny face away, if you will. I do it about once every 6 months. It's not painful. I mean, it's not pleasurable by any means because it's an injection into your forehead, but it's not painful. I've never had any side effects. I've never had any bruising. It's really actually painless for the most part.
I'll ask a quick question of Dr. Pereira. Dr. Pereira, what is the #1 cause of death for women in the United States? Heart disease. All right, so if you go down the list, heart disease, heart attack, aneurysm and stroke, taken together is #1. #2 is cancer. The #1 cancer is lung cancer that kills people. #2 is colon cancer that kills men and women. #1 cancer that kills women is breast cancer. Okay, after lung and colon cancer. Next in line is automobile accidents. Next in line is emphysema from smoking. Next in line is diabetes, complications of diabetes, and within the next 10 years it will probably change places with emphysema. And then finally, Alzheimer's or old age. So if you want to die with old age, you have to get through all those other things first. How can I have more energy every day? Who wants to?
That's a very common complaint. People tells that they feel that that spark is missing, that they have to go through a couple of pots of coffee through the day. Many times, even for people that are not obese, that's a sign of sleep apnea. If problem with sleep apnea, you sleep but you do not rest. And take it from us that have lost a few nights being on call. The next day is miserable. And if you have sleep apnea, it's almost like you being on call every night, and your days have very poor quality. People have a few apprehensions about treating sleep apnea, about using the mask. They feel they're going to be claustrophobic if they get treated. But those who adapt to the mask, they don't want to part with it. They feel so much better. So talk to your doctor. If you feel that that spark is missing, that could be a sign of sleep apnea that can manifest not only as lack of energy, frequent headaches, elevation of blood pressure in the morning, and increased risk of atrial fibrillation and other cardiac arrhythmias.
I'm waking up early around 4 o'clock a.m. and unable to get back to sleep. Do you know what could cause this? I never had caffeine. Dr. Young?
It's a very, very common question, and it pretty much sort of has to be handled on an individual basis. What I usually do is you go back and understand the patient's current medical diagnosis. You go through a list of different things that they have. One of the most common and underdiagnosed or mostly missed is these dawn phenomena. A lot of people who are diabetics or have had issues with maybe little insulin resistance, they run into an issue where their sugar actually bottoms out at 4 a.m. and that wakes them up. They don't know why they wake up, and they suddenly wake up because their sugar bottoms out and then their liver kicks in to make the backup sugar. So it's one of those very, very subtle early signs that we also need to analyze and dig deeper into. Maybe there are some hypoglycemic issues going on, whether you're treated or not treated. That's usually one of those common missed diagnoses. The other thing is, depends on what you have done. Waking up at that time of the night is like, how did you go to sleep? Did you eat heavy food before you went to bed, or did you have any alcoholic drinks or stimulating drinks or caffeine? Alcohol is another very, very common used sort of drink towards the end of the day to kind of calm yourself down, but that'll help you go to sleep quickly, but you'll have an interrupted sleep. It can wake you up later on, and it really messes the quality of sleep. So there are a lot of different variables that sort of need to be handled, and what I usually suggest is for you, any kind of a sleep disturbance you have, you sit down with your physician and go through all the symptoms from initiation of sleep to maintenance of sleep, and let the physician go through a whole sleep hygiene analysis with you. So that has a whole bunch of components, and that sort of has to be sort of custom labeled with what component of sleep hygiene that could be a possible disturbance. That it's a very, very common discussion that usually we're having on a daily basis. But there, as I said, there's no one right answer.
So we want to do a counterpoint now. Dr. Pereira, grab the microphone, and Dr. Barrett. We have, and here's the question, and then I'm going to ask you to elaborate a little bit. The question is, my husband is having cataract surgery the 21st of February. Is it all right for him to come off his blood thinners for a week, aspirin and Plavix? Would that be too dangerous? Now, I know, Dr. Barrett, when you operate, you face this probably every week. You're operating on someone who's on a blood thinner for a cardiac reason. And Dr. Pereira, then you give Dr. Barrett advice or the patient advice. So start with Dr. Barrett. How often does this come up?
In my practice, it comes up at least a couple times a week. Very common. With the cataract surgery, it's sort of a different angle than the things that I do. Very often with the procedures that I do, even though it would be better if they were off of their anticoagulants, often often in my case, I can just control the bleeding surgically if I need to, and just leave them on the anticoagulant throughout the pre and post-operative period. And only in certain cases do I need to take them off. I mean, granted, it's better, but if the reasons that usually Dr. Ferrer has them on it are sufficient, then I'll just leave them on it through the procedure. I don't know that that would translate into to a cataract surgery, though. That's sort of a different problem. I would have to defer to an ophthalmologist on that.
Right.
Okay, and the issue with aspirin and Plavix, or now there are other generation drugs that have similar action to Plavix, and the brand names are Effie and the Berlinda, they all take a while to get off the system. So if there's a major concern about the enhanced bleeding tendency that these drugs cause, stopping them the night before the procedure will really not solve the issue. Usually, when a concern about bleeding exists, these drugs have to be interrupted at least 5 to 7 days prior to the procedure. So the most vulnerable patients to the interruption of those drugs are those that have a recent stent, and by recent I mean within the past 12 months. The farther you are from the initial intervention where the stent was deployed and you were started on Plavix or one of these drugs, the lesser the risk that that stent will close. Interrupting those drugs too soon may cause an abrupt clotting of the stent. Of course, it becomes a balancing act. If you're dealing with somebody that's having a life-threatening bleeding by itself can cause a heart attack, and you don't want that to happen. Many times you are painted into a corner where you have somebody that had a stent a few weeks ago, and then they present with bleeding, and we have to stop these medications. Sometimes we're lucky, nothing happens. Sometimes we end up having to take this patient to another intervention. But if we're dealing with an elective situation, with a situation where we can defer a known life-saving surgery, we prefer to postpone it for at least 12 months after the intervention.
And I think that brings up, and the reason I did it that way was to point out that the most important part is communication. For the surgeon to know exactly what you're taking, including over-the-counter medicines and including herbs and supplements. For the surgeon, and why exactly, and the medical reason that you're taking it. And for the surgeon and your primary care physician or cardiologist to be in contact, and for the surgeon to say, you know, is it too soon to do this operation? Can I take him off Plavix? Can I take him off Coumadin for a week in order to do the surgery and then put it back on? Excellent questions. Thank you. The prize question of the day. We've got 3 questions. How long do hot flashes last? And hormone therapy or not? And then Dr. Malavarapu, how can you improve bone density? And we'll let Dr. Sapan talk about hot flashes, hormone therapy, and then Dr. Malavarapu, failing or without hormone therapy, the next step then for bone density.
Menopause. Okay. It does, but the average age of menopause in the U.S. is somewhere between 51 and 52 years old. It's just an average. Some women go, after the age of 52. Some women go before the age of 52. A lot of it is, hereditary and genetic. So whatever age your mom or sister or aunt went through menopause, you expect to go this change around the same time. It's not, menopause is not one set defined interval. It's a transitional gray zone, which happens around the age of low 50s to late 40s to early 50s. Most common symptoms of menopause. Number 1, exactly, hot flashes. Number 2, night sweats. And number 3, mood swings. And then further on down the list, there's vaginal itching, dryness, etc., etc. symptom in women when menopause, it varies from women to women. It's been reported as being a flushing sensation working from the bottom up, most prominent on the chest and the face. For some women it lasts a few seconds, others it can last several minutes. Then now the exact duration, if you're asking from a long-term point of view, it could be from a couple months to a couple years. It varies from women to women, again, associated with their family history and how their mother and sister went through it. All studies have shown the best, or the most effective treatment for it is hormone replacement therapy. During the menopausal years, your ovaries will basically start to not quite function up to 100%, start to peter out, and the estrogen that they secrete isn't quite up to what it used to be. So it's that lack of estrogen which causes many of the symptoms which are described, including things like bone loss. Hormone replacement therapy has been shown, consistently shown to be the most effective and consistent treatment to treat these symptoms of hot flashes and night sweats. There are caveats and side effects of hormone therapy. About a decade or almost 2 decades ago, there was a study called the Women's Health Initiative, or WHI, which threw out a lot of information, some of it which was misreported by the media as to certain effects of hormone replacement therapy, more specifically breast cancer, colon cancer, strokes, or venous thrombotic events such as blood clots to the legs and to the lungs. Generally, what we recommend is after talking to the doctor and figure out your past medical history, surgical history, figure out if you're at high risk of things such as, or if you've had a history of breast cancer or blood clots. The general consensus is for women to take hormone replacement, the lowest dose for the shortest period of time. And that's intentionally vaguely worded by the committees that be, because it varies from women to women as to what the best duration is and what the best dose is. Because you and your doctor may have to tweak the doses around to figure out what works best for you, what controls the mood swings, and what controls the hot flashes. For women who, again, have some medical comorbidities, such as a history of breast cancer, uterine cancer, blood clots, there are other alternatives to hormone replacement therapy. Sometimes there are other medications such as what we call SSRIs, there are things like SSNIs, or SNRIs, which are various forms of medication to help control mood swings as well as the hot flashes. You don't always need to be on medications to control these menopausal symptoms. There are very easy things such as behavioral therapy, such as modifying what you wear, wearing layered clothes. So when you do have when you do have a hot flash, you can take off the jacket, take off the sweater, take off the t-shirt. Then when the hot flash resolves, you can go ahead and put those layers back on. For night sweats, carrying or putting a big jug of water next to you, not to throw on you at night, but to really drink when the night sweats occur. And then last but not least, the supportive husband is another big player in the game.
You can tell he's had this conversation more than once.
Yeah, and I can't say I've never had my hot sweat or hot flash. Never had it.
I'm going to interrupt here. He mentioned the Women's Health Initiative, and that is actually one of my favorite rants. How many of you are afraid of hormone therapy after hearing from the Women's Health Initiative? Let me give you the raw numbers. In the Women's Health Initiative, there were 5,000 women on each arm of the study. 5,000 women taking Prem-Pro, hormone replacement therapy. 5,000 women not taking the placebo. In the placebo group, there were 24 breast cancers. In the hormone group, there were 32. The reporter on CNN that morning, Melanie watched me as I spit my coffee in her. The reporter on CNN that morning said, "Ladies, this just in. If your doctor has you on hormone therapy, hormone replacement therapy, he is increasing your risk of breast cancer by 30%. That was the headline on CNN. I do agree that 8 is 30% of 24. Out of both arms of the study, the 24 and the 32, there were no breast cancer deaths. They were detected by mammogram, dealt with. Those women still haven't died. You have to get down to the study and see the real numbers. So now, an increase in 8 breast cancer is out of 10,000 women. Are you still scared? Well, yeah, because it's cancer. But are you unreasonably scared? Well, you shouldn't be. You should talk with your doctor and talk about a middle road and alternatives. Dr. Malavarapu, in the case of the woman who's not taking, or in addition to taking hormone replacement therapy, we want to increase her bone density, what would you recommend?
First of all, it's good to prevent osteoporosis from happening, and for that you have to start doing moderate exercise, mainly the weightlifting or any weight-bearing exercises to prevent osteoporosis. But once osteopenia or osteoporosis sets in, the best thing to do is take calcium and vitamin D. And if the osteoporosis is already set in, then we have several medicines ranging from Actimel to Fosamax and several other medicines to give. They're all injections that can be taken once a year for osteoporosis, and the main side effect is pain-like symptoms with that. But again, to prevent the progression and to not getting worse, the best thing to do is do weight-bearing exercise and take your calcium and vitamin